Welcome to another episode from a Veterinary Medicine Digest. Today, we delve into one of the most frightening and immediate emergencies faced in canine medicine, gastric dilatation and volvulus, often known colloquially as bloat. This is a life-threatening condition defined by the acute and pathological twisting of the stomach around its own axis, usually in a clockwise direction, trapping gas inside. This torsion creates a catastrophic situation that requires rapid diagnosis, aggressive stabilization, and emergency surgery if the patient is to survive. When the stomach twists, it obstructs both its exit, the pylorus, and its entrance, the cardia. As gas rapidly accumulates, the distended stomach compresses major blood vessels within the abdomen, particularly the vena cava and portal vein. This compression drastically reduces the flow of blood returning to the heart, plunging the patient almost instantly into a state of shock, characterized by profound hypovolemia and obstruction. The severe consequences include oxygen deprivation, leading to gastric tissue ischemia and necrosis, injury to the heart muscle, translocation of bacteria from the compromised gut leading to sepsis, widespread systemic inflammatory response syndrome, and potentially fatal blood clotting disorders known as disseminated intravascular coagulation. Survival hinges on rapid, coordinated intervention, focusing first on stabilization and then on surgical correction. The at-risk patient, profiling the susceptible dog. Gastric dilatation and volvulus typically affects middle-aged to older dogs, particularly those of large or giant breeds, which are predisposed due to their characteristic deep chest conformation. Breeds commonly described as being highly susceptible include the Great Dane, the German Shepherd dog, the Standard Poodle, the Weimaraner, and setter breeds. Indeed, the lifetime risk for dogs in these susceptible breeds can be estimated to be between 4% and almost 37%. Increasing age is consistently identified as a specific risk factor. Beyond breed and age, various factors contribute to the risk profile. Genetics undoubtedly play a role, as dogs with a first-degree relative, particularly a parent, affected by gastric dilatation and volvulus have an increased risk. Genomic analysis has even identified specific markers associated with genetic susceptibility in some breeds, such as the Great Dane, possibly through alterations in the intestinal microbiome. There are also physical characteristics and concurrent health issues that raise concern. A deep chest conformation, quantified by an increased thoracic depth-to-width ratio, is a known risk factor. Pre-existing gastrointestinal diseases, such as inflammatory bowel disease or the presence of gastric foreign material, may also increase susceptibility. A particularly complex area of risk involves the spleen. The close anatomical association between the stomach and spleen means that splenic disease, such as a large splenic mass or splenic torsion, may increase the laxity of the ligaments that support the stomach, thereby increasing the risk for volvulus. The relationship between previous spleen removal, splenectomy, and the subsequent development of gastric dilatation and volvulus has been studied extensively, with conflicting results. While some studies show no increased risk after splenectomy, one significant case control study found that the odds of developing gastric dilatation and volvulus in dogs with a history of previous splenectomy were a staggering 5.3 times higher than in dogs without such a history. This highlights why many clinicians consider performing a prophylactic gastropexy, the surgical procedure to tack the stomach, at the time of splenectomy, especially if other risk factors are present. Diet and feeding habits have also been implicated. Feeding a large volume of food once daily, rapid eating, and even eating from a raised food bowl have all been hypothesized to increase the risk. Owners are often advised to feed smaller, more frequent meals to at-risk dogs to prevent recurrence. The pathophysiology of crisis, systemic collapse. The clinical presentation of gastric dilatation and volvulus can vary dramatically, ranging from a mildly affected patient who is stable and alert to one who has collapsed in irreversible shock or even already deceased. Typical signs include pacing or severe restlessness, profuse salivation, ptyalism, marked abdominal distension, weakness, collapse, and, critically, non-productive retching or vomiting, indicating the obstruction of the gastric entrance. The underlying physical rotation is typically 180 to 270 degrees in a clockwise direction. This rotation, or torsion, rapidly initiates a complex series of physiological disasters. The immediate life-threatening consequences stem from two key areas, the cardiovascular system and the gastric wall itself. First, cardiovascular collapse. The immense gas distension in the stomach presses directly upon the major intra-abdominal veins, the portal vein and the caudal vena cava. This physical obstruction dramatically impedes venous return to the heart, quickly leading to reduced cardiac output and subsequent tissue oxygen delivery. Dogs typically present in a combined state of shock, including obstructive shock due to vascular compression, distributive shock due to splanchnic pooling of blood and vasodilation, and cardiogenic shock due to arrhythmias. Second, tissue ischemia and injury. The stomach wall, especially the greater curvature, suffers from impaired blood flow due to the twisting, high intragastric pressure, and overall reduced cardiac output. This leads to gastric tissue ischemia, which, if left untreated, results in necrosis, the death of the tissue. Gastric necrosis is reported in a significant proportion of patients, ranging from about 10% to 41%. A crucial and often delayed effect is ischemic reperfusion injury, or IRI, when blood flow is restored to the previously starved tissues, either by gastric decompression or surgical derotation. A surge of reactive oxygen species is produced. These highly damaging compounds inflict paradoxical tissue damage, causing cell death and triggering the widespread inflammatory cascade that leads to systemic inflammatory response syndrome and multiple organ dysfunction syndrome. Organs commonly affected by this multi-systemic damage include the heart, the lungs, the kidneys, and the coagulation system. Cardiac manifestations, arrhythmias, predominantly of ventricular origin, are a hallmark complication of gastric dilatation and volvulus, occurring in approximately 40% to 70% of cases, often within 12 to 36 hours after onset. These arrhythmias are often attributed to myocardial ischemia caused by reduced coronary blood flow and the release of pro-inflammatory substances. Coagulation dysfunction, blood clotting disorders, including the severe condition known as disseminated intravascular coagulation, are frequent in dogs with gastric dilatation and volvulus. This dysfunction is driven by systemic inflammation, tissue hypoxia, and endotoxemia, and may manifest as either an early, excessive clotting state or a later, catastrophic bleeding state. Renal dysfunction, acute kidney injury, although receiving less attention than cardiac issues, has been documented in dogs with the syndrome. The potential mechanisms involve global hypoperfusion due to shock, inflammatory injury, and microthrombosis. Respiratory dysfunction. Dogs are at high risk of developing aspiration pneumonia, especially postoperatively, and multiple studies indicate that pneumonia is a poor prognostic indicator. Gastric dilatation itself also contributes to respiratory difficulty by increasing intra-abdominal pressure, restricting the caudal movement of the diaphragm, and preventing normal inspiration. The race to stabilization, diagnostics, and initial treatment. Given the severity of the systemic effects, rapid diagnosis and stabilization are paramount. The immediate goals are twofold: aggressive fluid resuscitation to correct the hypovolemia and shock, and gastric decompression to relieve pressure on the vital blood vessels. Vascular access and fluids. Because blood flow from the caudal half of the body is significantly reduced by the massive stomach, large-gauge intravenous catheters are typically placed in the cranial body, usually in the cephalic or jugular veins. Fluid therapy, generally involving balanced isotonic crystalloids, is initiated quickly in boluses to restore circulating volume. Gastric decompression. Decompression must be performed as soon as possible. Techniques include 1. Trocherization or percutaneous gastric decompression. This involves inserting a large-gauge needle or catheter directly into the most distended, tympanic, drum-like part of the stomach, usually after a septic skin preparation, and can often be performed in an awake patient. 2. Orogastric intubation, where a tube is gently passed down the esophagus into the stomach. This method usually requires heavy sedation or general anesthesia to be tolerated and minimizes the risk of the patient biting the tube or inadvertently aspirating gastric contents. Clinicians must use gentle pressure to navigate areas of resistance, most commonly the lower esophageal sphincter, to avoid tearing or perforating the esophagus. An increasingly studied prognostic tool during this phase is lactate measurement. Lactate, a product of anaerobic metabolism, accumulates when tissue oxygen delivery is insufficient. High-presenting lactate levels, generally above 6 millimoles per liter or higher, are repeatedly associated with poorer survival and an increased risk of gastric necrosis. Even more significant than the initial level is the concept of lactate clearance. Improvement in hyperlactatemia following fluid resuscitation is a positive prognostic indicator for reduced gastric necrosis and improved patient survival postoperatively. Other critical parameters monitored during stabilization include continuous electrocardiography, as 40% of dogs with the syndrome develop ventricular arrhythmias. Blood pressure monitoring is also vital for assessing the effectiveness of fluid resuscitation. Preoperative thoracic radiography is recommended to screen for aspiration pneumonia, and coagulation tests are assessed to guide decision-making regarding blood products. Diagnostic confirmation. The diagnosis of gastric dilatation and volvulus is typically confirmed using abdominal radiography, specifically a right lateral projection. A classic finding in the most common 180-degree torsion is the double bubble sign, which signifies gas distension and compartmentalization of the stomach, often accompanied by craniodorsal displacement of the pylorus. However, not all gastric twists present typically. A recent study investigating the rare, highly dangerous 360-degree volvulus found that this severe rotation is frequently misdiagnosed radiographically as simple gastric dilatation without volvulus. In a 360-degree twist, the pylorus tends to remain near its normal position, eliminating the telltale compartmentalization seen in the 180-degree torsion. Clues for a 360-degree volvulus include a significantly higher heart rate upon admission compared to simple dilatation, severe esophageal gas distension, and the absence of gas distension in the small intestine. Another unusual presentation is counterclockwise gastric dilatation and volvulus, a rare condition where torsion is limited to 90 degrees around the gastric axis due to the fixed position of the duodenum. Similar to the 360-degree twist, this counterclockwise rotation lacks the characteristic double bubble sign, and the esophagus remains open, making decompression easier. Misdiagnosis of these atypical rotations can critically delay definitive surgical intervention, leading to higher rates of complications and death. Surgical correction, derotation, and gastropexy. Surgical intervention must be performed swiftly to limit the duration of tissue ischemia. While some time spent on medical stabilization is warranted, surgery should not be delayed unnecessarily, as complete normalization of perfusion parameters may not be possible without relieving the physical obstruction. The operation, typically initiated through a ventral midline ciliotomy, has three major objectives. 1. Gastric derotation and decompression. The immediate primary goal is correctly repositioning the stomach. For a typical clockwise volvulus, the surgeon will gently pull the pylorus from the left side of the dog's abdomen to the right and ventral direction, while simultaneously pushing the fundus dorsally into the dog's left. Sometimes, further intraoperative decompression is necessary via an orogastric tube or needle decompression to assist in repositioning the massively distended stomach. 2. Evaluation and resection. After derotation, the surgeon must evaluate the stomach for signs of gastric necrosis, particularly along the greater curvature and fundus. Necrotic or non-viable areas are indicated by discoloration, such as gray, white, black, or green, a thin texture, or lack of capillary perfusion. If non-viable tissue is found, a partial gastrectomy must be performed. Likewise, the spleen must be evaluated. Splenectomy is recommended if there is evidence of thrombosis, lack of palpable splenic artery pulse, or discoloration, and this procedure is required in roughly 9 to 23% of patients. The need for either partial gastrectomy or splenectomy is consistently associated with increased complications and increased mortality rates in the postoperative period. The survival rate for dogs requiring both partial gastrectomy and splenectomy can drop significantly. 3. Permanent fixation. Gastropexy. This step is essential following the correction of gastric volvulus. Without a permanent surgical attachment of the stomach, the rate of recurrence of gastric dilatation and volvulus exceeds 75%. A gastropexy creates a permanent adhesion between the pyloric antrum of the stomach and the body wall, typically on the right side of the abdomen. Multiple techniques exist for achieving a right-sided gastropexy, with similar efficacy in terms of preventing recurrence. The incisional gastropexy is the most commonly reported technique, valued for its technical ease, effectiveness, and low morbidity risk. This involves making parallel incisions through the seromuscular layer of the pyloric antrum and the transversus abdominis muscle, then suturing the corresponding edges together to form the permanent adhesion. Other methods include circumcostal gastropexy and belt loop gastropexy. Newer materials, such as barbed, knotless suture material, have been shown to shorten surgical time compared with traditional knotted suture. Postoperative intensive care. Managing the aftermath. The period immediately following surgery is critical, as intensive postoperative management is essential for patient survival. Therapy is focused on maintaining tissue perfusion and aggressively monitoring for the complications associated with multi-organ dysfunction syndrome, especially the effects of ischemic reperfusion injury and cardiac issues. Managing ischemic reperfusion injury and arrhythmias. The restoration of blood flow during surgery means the patient now faces the dangers of ischemic reperfusion injury. Clinicians frequently monitor continuous electrocardiography for ventricular arrhythmias, which may develop within the first 2 days post-surgery. If these arrhythmias risk decreasing cardiac output, treatment is initiated, usually with intravenous lidocaine boluses followed by constant rate infusion. Interestingly, lidocaine, besides being an antiarrhythmic, may offer secondary benefits in reducing ischemic reperfusion injury, acting as a gut motility promoter and providing analgesia. Early lidocaine treatment, started even before gastric decompression, has been associated with significantly decreased rates of acute kidney injury, cardiac arrhythmias, and multiple coagulation disorders. Pain and gastrointestinal support. Gastric dilatation and volvulus is an extremely painful condition, and strong opioid analgesics such as morphine, fentanyl, or methadone are highly recommended. Nonsteroidal anti-inflammatory medications, however, are generally avoided due to concerns about reduced gastric perfusion and the risk of gastric ulceration. To address the frequent gastrointestinal upset, patients are often given antacid medications, such as histamine, 2 receptor antagonists, sucralfate, or proton pump inhibitors. If postoperative gut immotility, ileus, or regurgitation occurs, prokinetics like metoclopramide are indicated. Nutrition and recovery. Early enteral feeding is considered vital for promoting the recovery of gastrointestinal motility and maintaining the patient's nutritional status. If the patient is awake and alert, food and water are offered. Otherwise, nutritional support via feeding tubes or parenteral nutrition is considered for patients who remain inaptent. Prognosis and mortality. Despite the severity of the syndrome, survival rates for surgically managed patients are generally encouraging, ranging around 77 to 88%. Overall mortality rates reported in the literature, which include patients who undergo euthanasia preoperatively, range from 10% to 28%. Poor prognostic indicators that clinicians must watch for include hyperlactatemia that shows minimal or no improvement despite aggressive fluid therapy, the necessity of a splenectomy or partial gastrectomy due to necrosis, as these procedures are associated with increased mortality and longer hospitalization times. Cardiac arrhythmias, both before and after surgery. Low body temperature upon admission. Severe systemic compromise, such as depressed or comatose mentation at presentation. A prolonged time interval between the onset of clinical signs and presentation to the hospital. The unanswered question, motility and etiology. While treatment protocols are well established, the exact etiology of gastric dilatation and volvulus remains largely unknown. The syndrome is clearly multifactorial, but research continues into whether fundamental problems with gastrointestinal motility are a predisposing factor rather than just a consequence. Gastric motility involves complex patterns of contraction, particularly the interdigestive migrating contractions, which cycle every 90 to 120 minutes to cleanse the stomach of indigestible solids. Abnormal gastric motility patterns and delayed gastric emptying have been observed in dogs following gastric dilatation and volvulus correction. Studies suggest that these motility abnormalities are associated with the disease process itself, rather than with the corrective gastropexy procedure. The theory exists that impaired motility, perhaps influenced by hormones or stress, leads to repeated subclinical episodes of gastric distension, which eventually stretch the gastric ligaments to the point where catastrophic rotation, the volvulus, can occur. If abnormalities in motility could be identified in at-risk dogs before they develop the condition, it would confirm a causative relationship and revolutionize prevention. Tools like wireless motility devices are promising for non-invasive assessment of gastrointestinal transit times, potentially helping to unravel this mystery in the future. It is also important to remember that gastric dilatation without volvulus can occur even after a corrective or prophylactic gastropexy. This phenomenon, where the stomach distends but does not twist, supports the idea that these dogs, likely predisposed based on breed and family history, harbor underlying motility defects. Prophylaxis, the power of prevention. Given the high lifetime risk for susceptible breeds and the devastating nature of the syndrome, prophylactic gastropexy. Performing the stomach tack before an emergency occurs is highly recommended for at-risk dogs. Prophylactic procedures typically aim to create the same permanent right-sided adhesion between the stomach and the body wall, but employ minimally invasive techniques to reduce patient morbidity and surgical time. These techniques offer comparable strength to open surgical gastropexy methods. The minimally invasive options include laparoscopic-assisted gastropexy, which uses a laparoscope for visualization and a small incision through the right body wall to exteriorize the pyloric antrum, allowing the surgical adhesion to be created. Total laparoscopic gastropexy, which uses specialized instruments and sometimes barbed, knotless suture material to create the permanent adhesion entirely within the abdomen. This technique is associated with lower postoperative pain scores and inflammation compared to traditional open surgery. Radiologic-assisted techniques, which utilize fluoroscopy to guide the placement of temporary T-fasteners into the gastric lumen, facilitating the subsequent incision and suturing. These prophylactic procedures can often be combined with sterilization procedures, although it is generally recommended that the dog be skeletally mature to ensure correct placement and prevent malpositioning as the dog grows. In conclusion, gastric dilatation and volvulus remains a veterinary emergency demanding swift, aggressive, and specialized care. While treatment approaches have improved survival rates significantly, particularly through refined stabilization protocols involving fluid management and decompression, and the use of life-saving interventions like lidocaine to mitigate ischemic reperfusion injury, the core questions about why the stomach twists remain unresolved. For now, surgical prevention through gastropexy remains the most reliable defense against this devastating disease. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging,